Howdy, y'all. Welcome back to the Show Up Fitness podcast. Today is a super, super big event. We have two physical therapists on the podcast today, Doc Q, Doc Katie. Thank you for taking the time. How are we doing today?
Excellent.
Fabulous. Love
And
that.
the other really cool thing is today marks the 400th episode for the Show Up Fitness podcast. We have been doing this for about 3 years. We love educating trainers and coaches, leveling up their skills. And we're going to talk about the course that they're going to be having in Texas and Austin. But before we do that, we want to ask a question from our followers. We have our own certifications, and a lot of trainers want to get into the horse's mouth per se. And so there's a question from Mr. Carlos, and he's on our platform, and he's asking, what do you feel is the scariest part of the personal training industry, but also the physical therapy industry? We both can tackle that one.
That's a good one. Q, do you want to take it away?
Sure. Yeah, I can start. Scary maybe isn't the word that I typically think of, but I appreciate the question and I understand where that's coming from. I think, when we talk about the word scary, what is scary? And I think about, okay, what are the barriers, or what are the intimidations? What are the imposter syndromes? What are things that maybe people struggle with, both on the clinical facing side as well as from the training facing side? I think for physical therapists, the scarier portion, or I guess some of the scariness. Somebody commented on a post that I recently put out as part of another podcast, where I was talking about how trainers and and people that work as coaches really kind of are this front line of healthcare. That you're seeing people more frequently. You have a much better touch point of, they're going to be the ones that tell you they're in pain first, maybe, and even in some cases as a personal trainer, and maybe this is part of the scary part, is that, like, you're going to have times where people don't feel good, where you overshot, or they just had, some aches and pains pop up as part of normal training, or even a significant flare as they were lifting. They heard a pop and, like, something really hurt. And I think that's not something that's wildly uncommon, despite people being responsible and trying to do their very best. And I think that on the personal training side, everybody's always so scared of hurting people that sometimes we end up managing people away from load so much. And, I think that it's going to happen. So you have to acknowledge, and even, like, help people acknowledge on the front end, that, like, things are not always going to be optimal and perfect. And that flare-ups, especially if you've had any kind of, significant pain, injury history, those things are very likely to come back at some time point, and for reasons that have nothing to do with the exercise selection, nothing to do with you progress them too soon. While that does happen, and while that can happen, and I'm not throwing that away, it's that there's some things that, even if you do all things right, you may still have flare-ups occur. Now, that also happens on the physical therapy side, albeit perhaps it can be more expected, only because we communicate about it up front. But it can even be more pressurizing, because they're coming for you specifically to solve that pain. And now, if you have somebody who has a flare up, well, are you just a bad provider then? Because your whole goal isn't just to train and to push weights. Now the pressure is upon you to fix, quote unquote, fix the pain. And now you have a flare up. That's almost worse sometimes than being a personal trainer. And so I think on both sides of things, we get so averse and scared of hurting people that, sometimes we nocebo things, or we have a very negative affirmation kind of talk and language from two sides of things, where we say, if you don't work out, all of these bad things could happen in your life. If you don't work out, you may get fat. If you don't work out, and I think that we need to get away from that and have more positive messaging in terms of, like, here's all the things there that you could stand to gain from exercising, both socially, from a mental health perspective, from prevention of non-communicable diseases, from, pain, injury prevention, all those kind of things. Like, it's all wrapped into all the huge positive messaging of interacting with weights. Now, it doesn't even have to be wildly heavy to start. We have good evidence that weightlifting and training doesn't necessarily have to be stimulated by lifting only heavy loads. In fact, lifting moderate loads, there's lots of different ways to progressively overload someone. That could be progressive ranges of motion. That could be progressive adding a set. That could be adding a few more reps at the same weight. There's a lot of ways of what progressive overload means, that you don't have to necessarily just load hit people heavy. And I think maybe that's where some people get a little bit inundated with the, what's on social media, and maybe a little bit intimidated, and the scary part. My point is that we are trying to promote a public health message that engaging with physical activity is extremely positive for a host of benefits that go beyond just performance benefits, but can even be positive for pain and in the rehab setting as well. And that we shouldn't be scared of when people have flare-ups, because that's a normal part of living human life. Even if you were very sedentary on the couch and you never lifted weights at all, and then you were doing laundry or doing dishes and you threw out your back or something like that, those are very common experiences, whether or not you're being physically active. So we shouldn't be too scared of that. And hopefully that kind of at least covers some of that question. I know I said a number of things there. What would you say, Katie?
Definitely in agreement. I think that's a huge part of our the stuff that you and I are so passionate about, of really kind of making people realize, like, pain. Craig Liebenson, we were speaking of him earlier. He talks about this a lot. Pain's going to do what pain's going to do. So we kind of have to understand that pain is a really normal part of being a human without being dismissive. That's a hard thing to do. We can normalize it, but we can also make people unfortunately, sometimes that message can be received as like, okay, well, maybe we don't care. It's definitely not that. But it's a part of life. So how can we work on things that improve every other aspect of quality of life, even with if you are experiencing pain? I think of it as making, if your pain is this size, you have to make your life bigger around that pain, because sometimes it's going to be a part of our lives that we deal with. So I definitely agree with all of that stuff. I think something else that could be maybe considered scary, or at least just quite challenging to navigate, is a lot of our jobs kind of end up becoming undoing harmful narratives that people come to us with from what they've been told in the past, or the information that they get elsewhere, or what somebody else has told them before about their pain, or about these kind of like predetermined limitations that they think that they have. And that can be really difficult and kind of scary to navigate, because you are trying to help somebody come to a new conclusion who's pretty firmly in a belief that is like the opposite of what yours is about their pain, their function, how resilient they are. And that can be tough to navigate. Like, this is stuff that Q and I talk about a lot. Like, we don't want to be like bulls in a china shop and just be like, you're wrong. Everything you've ever been told before was wrong. The person you worked with before sucks and was wrong. Like, we can't send that message, but we have to figure out a way how to navigate and maybe help people see pain in a different light. And those conversations, I guess in theory, could be scary. Like, it's hard to have those conversations with people, but I think it's a big part of our job too.
When I was talking to my students about this question, we talked about the personal training industry. Obviously, the entry standards are pretty low, but the last 2 years I've been to about 30 lifetimes, and it was interesting when I survey these 700 plus trainers, how many of you have been to a hands-on learning course? I can't tell you how often it was people come up to me and say, "This is my first time." And it's really just mind blowing that it's like, we're personal trainers, and so many trainers read, it's an outdated textbook. These private equity firms have a lot of money to pump in marketing, and then all of a sudden you think you're qualified, but you don't have hands-on learning. But I just think it's so important for trainers to get in the trenches and learn from people like yourself. And now I'd be interested to hear what your thoughts are on this, not to come off as negative, but from the physical therapy side, I really feel like that halo effect plays a role. I've met with so many physical therapists who, they treated me very delicately, and they almost started out with a fear-based principle. And then there's therapists I've met with who just didn't look the part of the therapist. And it's like, the thing about you two, like, I would go to you and be like, whoa, you're badasses. You look the part, you talk the part, you're super educated. And I'd soak up the information. But I feel like on the other side, there's some coaches that really just are a little too delicate, and maybe we could practice what we preach a little bit more.
Definitely. Yeah, I think that is kind of a common theme in the rehab space. I think in school, we're taught very well how to like manage complex medical cases that do need to be handled with a little bit more, delicate nature, I guess, or maybe they have some considerations that we have a lot of, again, medical factors to consider. Something that Q and I think get really frustrated with, and I know you could speak on this, Q, as well, the over medicalization of musculoskeletal rehab and just orthopedic stuff is a big area of frustration for us, because unless there's pretty specific like neurological red flags that are present, or like a specific mechanism of injury, or like a traumatic event occurred, there's been this extreme like over medicalization an over clinicalizing, if we can make that a word, of a lot of just like aches and pains and stuff that people are going to experience as humans. And not everything needs a specific diagnosis. Not everything needs to be handled really delicately. And I think that is like, by and large, if you're an outpatient orthopedic physical therapist, like that's more of what you're going to see, like somebody whose knee hurts when they go downstairs. It's not a medical emergency. And not to downplay that the pain sucks, it absolutely does. But more often, you're going to be met with cases like that, where it's a lot more about improving your overall health and fitness to have downstream effects on your pain outcomes and what your tissues are able to tolerate, as well as taking a more active approach that pushes people a little bit harder than probably what they're used to. So that's a big frustration. There's just this kind of low dose, very low level of care. That's honestly much lower than any training stimulus. So, how can we expect it to actually make somebody's tissues change that have been injured or that are hurt or that don't tolerate things well? It always just seemed to me this very obvious disconnect. Like, if we need progressive overload to achieve the goals of strength training, why do we not need it to achieve the goals of getting somebody healthier after an injury? Like, it seems obvious to, I think, practitioners like us, but it's still not quite the norm, which is frustrating.
Yeah, I think that, okay, so to separate maybe the fields of like a musculoskeletal healthcare provider versus personal training, it's if somebody's experiencing pain or some kind of an injury, regardless of whether there was, some kind of trauma associated, and that may up the ante a little bit. If there were associated trauma or something more serious, of course, we want to dig a little bit deeper into what was the mechanism of that particular injury. But to differentiate the field slightly, one of the things that you go to school for earning the doctor of physical therapy thing, the field to become a chiro or a doctor of physical therapy, earning some kind of medical license, is just simply to say with a little bit higher certainty that we have a little bit more clinical testing of what this thing is not. And that may be what it is not is a neurological pathology or some kind of an upper motor neuron kind of situation when in the cases of low back pain, or even in the cases of normal training musculoskeletal aches and pains. Is this a bone stress injury? Is this more of a joint related pathology of an osteochondral lesion or something more that's more cartilaginous, or is this more soft tissue? And of the soft tissues, is this more muscular or is this more tendinous? Is this ligamentous? Could there be an actual ligament tear here due to like joint play and joint laxity in some of the reports or the mechanism of injury? Things like that of ruling out or trying to tailor down a little bit more specifically on what is going on. And that's fine. And that's where I think we try to create a collaborative process between personal training and physical therapists, where you don't come see a physical therapist and then just get your training derailed and then get inundated with all of these things and pathologizing and over medicalizing of like, oh, well, you're tight here and you're weak here, and we need to image this, and oh, your fascial lines are off here, and oh, you're lacking this internal rotation, because probably all that kind of stuff doesn't matter as much. We have ideas of like based on what tissue is being insulted here, or is the injury mechanism per se. But oftentimes I think where Katie and I get so much more frustrated on the clinical side is that then gets extrapolated into a world of let's use a bunch of pseudoscientific sounding phraseologies and make it sound that this thing is this big scary mystical thing and you need to come see me to fix this thing, and that the modalities, the passive palliative care type stuff, and even the corrective exercises, if you will, are often sold as ways of fixing people and changing biomechanics and biology. And I think that they really are missing the forest for the trees, in that we are trying to help people navigate and sense make of their pain and why things are occurring the way they are. But we have to also then be good at either working with the individual or with the personal trainers and saying, well, what does the programming look like? And how do we scale this that we continue to help people be socially active in their physical activity lives and the things that they want to do that engage them with some kind of physical activity? How do we keep training parameters moving in the right direction? I just got off a call for a 90-minute call with Stuart Phillips, who is an excellent researcher and scientist in the field in the protein and musculoskeletal health, who talked a lot about anabolic resistance and metabolic factors. We know that like we're fighting an uphill battle with aging. We're fighting an uphill battle as a population level in society where we are already having a hard time engaging with enough physical activity or resistance training at baseline. That the last thing that we need to do as healthcare providers is over medicalize or pull people away from or out of environments where they're becoming physically active, and then making them feel like, oh, you're fragile, and because you've been lifting this particular way, that's why you hurt. We can't say those things. We actually don't have good data or information as to why certain things start hurting at different time points. Like even something as simple as like an ACL mechanism of injury has been hotly debated for decades. That we understand that, yes, if the knee becomes more valgus and doesn't flex right, and if there's some twisting mechanism, we know that the shin or the tibia needs to translate forward in order for the ACL to tear or occur. But then when we look at things like a depth drop, and you watch patients or clients or subjects jump off of a box and land with dynamic knee valgus, or when they squat with dynamic knee valgus, that has zero correlation with who goes on to go and tear their ACL. And that's become more and more apparent over the years now of more and more research that's come out that like we just can't say with a high degree of certainty that the reason why you hurt is for these reasons. And I think that our profession does a horrible job at that. And where we try to advocate a lot of is working with personal trainers to say, hey, listen, we can help consult with you and the client on what may be going on and what type of tissue deficit may be happening, and potential reasons why. But at the end of the day, the person still needs to interact with physical activity and engage with these things, because we know that this is going to have the most bearing on long-term health and non-communicable diseases and may help them overcome their injuries sooner. So let's just find the way that we can all work together on this without pulling people out of load and noceboing them, meaning that we're going to inundate them with these thoughts or these little gremlins, these little thought demons, that they're going to get hurt if they keep doing it this way, or that it's bad. We need to get rid of all that negative way of communicating. Hopefully that makes sense.
So, Doc, you're telling me that lower cross syndrome and just foam rolling your adductors and strengthening your glutes isn't the cure to cancer?
No, not I mean, yes, we can make funny jokes about like the cure to cancer, but sadly, the things like upper and lower cross syndrome, or the posterior tilt or anterior tilt of the pelvis, or the pelvis relation to the rib cage, is blamed and pathologized for all kinds of back pain, shoulder pain, abdominal strains, pec strains. We try to get these over biomechanical, pathoanatomical ways of viewing the human body, and yet none of them pan out in terms of the research. And you can see just as many clients in a day, let alone in a year, that will demonstrate all kinds of different movement strategies. And some of them have the pains that you may think that they should have based on this one particular model or system that you engage with, that you took some 3-letter acronym course to learn. And then you'll see just as many who don't have that at all. And in fact, they break the rules and may have the opposite thing that you would expect. So we can't say with certainty that any of those things actually are causative, and that just by fixing them that you're going to fix the person's pain. And that's where a lot of this stuff really just needs to die out and go away.
I think that's one of the challenging things where I try to critically think and surround myself by great coaches such as yourselves. And when I go and teach a seminar, we have some open-ended conversations. You'll have people very definitively say, "Well, they have low back pain because of an anterior pelvic tilt, and we need to release the psoas and strengthen the glutes, and that's what's worked for me. Therefore, it works. And also, I do have that corrective exercise certification. Therefore, I know more than physical therapists, obviously." And it's a difficult conversation to have, because you want them to kind of take their blinders off and look at other aspects of it. And that's why we're so big at within our courses. You should have a physical therapist on your team and have weekly conversations and talking to them about, like, I had a client who came in and they may have had this, but let's talk about, how I can, properly train them. But are there any contraindications or things that I can and cannot be doing? And I think that's a perfect little segue into your guys' course on low back pain, and really what they're going to be learning. And, one of the topics it talks about being able to know when to refer out those red flags. So do you want to, take the floor and just tell us a bit more about the course, and then we can dissect some of the talking points within that?
Yeah, for sure. I think something that Q and I are really passionate about is helping people to understand like once the very obvious scary stuff is ruled out, people are really safe to exercise. And in fact, there's very few instances when truly being told to not exercise is the right answer. And that's like a big takeaway that we want people to have from this course, especially for low back pain, because it's the scariest usually. It's usually the thing that most rehab providers and trainers feel the least comfortable with because back pain, no matter how minute it actually is, or no matter how relatively like not a big deal it is in terms of what tissues are dealing with it, it's always like big pain. The pain levels are high, the emotion is high, the stakes are high, and it's a very emotional process. And we probably all have experiences in our life where somebody we know close to us has had back pain for a long time and their lives look very different because of it. Or somebody was told that they need surgery, or somebody had a disc injury 20 years ago and they're still being told that's the reason for their pain. So we all have, I think, this kind of warped perception of what back pain is. And I think that makes it more emotional than a lot of other types of pain. So, a big goal that we have is to really make it clear and streamline the decision making process of unless these specific neurological things are present, or a mechanism of injury, or a traumatic event, or red flags that point to something systemically going on that's none of our scopes of practice, not PTs either. There's signs of infection, if there's signs in history that do make you think of something like cancer, that's none of us. That's not what any of us should be dealing with. But the reason we talk about it isn't to scare people, it's more to show you these are rare, they're very obvious. And then in the absence of them, you can have a lot of confidence that exercise is exactly what you're supposed to be doing with this person. And our big goal is like, we want people to feel really comfortable with a trainable menu for somebody who has back pain, basically meaning like, what's the list of all of the things that somebody can do that don't really trigger their symptoms? For me, like I have a history of disc herniation and back pain, and I deal with my flares and I work through that with Q. And for me, like most upper body stuff is pretty fair game. So I can always feel confident knowing, even if I'm in the midst of a flare, I have a trainable menu that I can pull from. So that's what we want to help coaches feel comfortable with. What's your trainable menu for any client that you're dealing with who's experiencing pain? And then the opposite of that is what's the stuff that currently does not feel like the client has access to it? They might be scared. It might be a position that triggers some emotional stuff about maybe how they think they initially got injured. It might just be a position that physically doesn't feel good right now. So, how do we start to build up entry points for those positions too? So, we have kind of two concurrent goals. I want to beef up as much as you can do without irritating your symptoms. And then I want to find that entry point for stuff that maybe right now feels a little bit off limits. And if we can do that for everybody, like that is a game changer for how people think about pain. It doesn't necessarily mean that you can't do anything or your training has to dramatically change. There might be instances when you're a little bit more acutely flared up. And that's also okay when we have to find ways to move that aren't triggering. And it might not only be about a training stimulus all of the time. Like for me, for example, when I had a more acute flare about last year, initially I kind of had to get through the process of like, right now, like today isn't about a training stimulus, and that's okay. It's about moving in a way that my body is getting positive messaging that I am okay, that I'm getting movement in, that I'm, keeping my brain a little busy. And that's okay if it starts that way. But our goal is to then transition. How can we make this a training session? And how can we do this in a way that builds up some confidence again?
Yeah, I think that what Katie started with at the very beginning of talking about what back pain is for most people, it is, I mean, it's scary because people can experience back pain to a degree where they literally can't get up off the floor. They can't move off the couch. They can't sleep. They can't sit. Like, it's so excruciatingly painful and debilitating at times that I think the level of anxiety that comes with that is how could something that is so painful and so debilitating not be medically serious? Because anything else that you would experience in life to that degree that shuts your life down that much, you go to the emergency room for because you literally couldn't even go to work that day. And now you have on the other side of this coin, we're saying, well, in the absence of these other red flag symptoms, it's actually not serious. And I think that really messes with people's heads because it feels extremely serious. Their subjective experience is so serious. And I think even the non-specific low back pain talk, I still hear back and forth. I even hear, some folks on larger podcasts that are clinicians of some kind say what a stupid diagnosis that is, or what a dumb thing. Non-specific low back pain is never a thing. And it's silly to say that because it 100% is a thing, but it's just not a specific diagnosis. And when we say non-specific low back pain, it just means that our ability to identify with any kind of real clinical reliability what is the source or the root cause of this pain, and therefore what should be done to fix it, air quotes, is so poor. We don't have any kind of reliable imaging related information or databases or studies that reliably show that when something looks aberrant or abnormal on an imaging finding, that it will match the degree of symptoms or the type of symptoms that people will have. We also know from clinical signs and symptoms that we don't have good prognostic value type tests of how long will this pain occur for. I've had people that are just completely in debilitating pain who can't get off the couch, and then 2 days later they're telling me like, you know what, I'm actually like 80% better today. And 2 days ago I was like in tears thinking my like whole training career was over. And I have other people that have these kind of minor flares, it takes them down by 20 or 30% in their training, but it just lasts forever. It can just go on and on and on, and it's really challenging and up and down. So my point is that like we just say non-specific low back pain because we don't know with any kind of clinical certainty, no matter what kind of imagery used, no matter what guru out there on some podcast is saying, they're charlatans if they are saying that they have certainty around identifying why back pain occurs and what exactly needs to be done about it. And I think Katie and I and Craig Liebenson, who we talked about earlier, and there's so many others in our space that are more evidence-based practitioners. What the thing that we're trying to communicate is that we don't have a particular system or model that we're selling, that you don't just watch people move and identify very specific patterns and then say, oh, yep, you have this pattern and you're rotating this much or flexing or extending this much. Therefore, you follow our system, our protocol, and boom, you're going to fix everybody. That's not how this works. It's so much more individualized and nuanced, first of all, and there's no fixing back pain. 80% or more of adults across the world will experience low back pain at some point in their life, irrespective of activity levels, strength, work, labor environments. And sure, there's some predictive models that have shown that certain labor environments, socioeconomic demographics may play into who experiences these things more. There's probably some collection data bias on some of those parts. So my point is that like most adults, most humans who live life will experience some kind of back pain at some point in life. Your risk goes up for experiencing back pain again once you've had it in the past. That's true for any injury, that like once you've experienced the injury before, your risk or potential likelihood of experiencing something similar in a similar area goes up. That's just part of reality. We get that. So the charlatans and people out there saying, oh, this is how you fix back pain and just follow our system, we're trying to move away from that and say, hey, let's not try to eradicate this thing that's a very normal part of human experience, the same way that gray hair, that wrinkles, all the other parts of aging occur to everybody. And the only certainty that we have in life is that we will all die. We know that for sure. And I don't mean to be overly morbid, but like you're not going to optimize life so much that you just don't die. We know that. So we need to think about back pain in terms of, hey, yes, we're trying to maybe reduce the likelihood or reduce the effects of back pain on people, but we're not trying to eradicate or solve or fix back pain. We're trying to create a model in which people can then, yes, have a trainable menu that they can sense make of this thing. Pain and suffering, I tell this to all my clients, are very different things. That the sensation of pain does not necessarily mean loss of life, loss of identity, loss of function in all cases. It's just a sensation. Where people experience suffering is all the things that comes with that pain: the loss of identity, the loss of function, the loss of social engagement, the loss of what it means for their life now and in the future. That's the suffering piece. So what we're trying to do is reduce suffering, and we're trying to help people navigate and make sense of their pain. And a really good pain researcher and researchers, I should say, in Australia have used the quote and said, just because people have beliefs, you don't need to necessarily change belief to change behavior. And as trainers, And as physical therapists, we're trying to move the needle as on a societal population level on what are the behaviors that we start falling into more and more. What are the types of behaviors we push towards that keep people moving, that help them contextualize their pain and do more and function better in spite of experiencing something that's completely human and something that will likely happen to just about everybody. And it's sad because you even in like really popular TV shows, like the two Apple TV shows that I just recently noticed this in, Ted Lasso, new season is out and right now, and I know that a lot of people love Ted Lasso, but you know it's sad that they made the head physio who they did and the type of demographic, and then what physio is and what it's communicated to be is that it's all just palliative hands-on care. And then another show, Your Friends and Neighbors with John Hamm, they're all talking about the type of physio that they get, and it's my physio's got magic hands and I need this physical therapy. And you know, even in the show, he experiences a period of time where he like throws out his back, and just everything that's surrounding about why you have back pain, of because you were an athlete and you got beat up early in life and now you're wear and tear and paying the price, and then what you do when you're experiencing pain. My point is that in these two TV shows, it's so evident of where heuristically society still is from what we see in the entertainment, even as well as like what you see on social media, that it's so poor and so off from a lot of the messaging that Katie and I are trying to communicate. And we're simply trying to help pull society up and level up both trainers and coaches, as well as physical therapists and chiropractors, to simply do better for people than what the normal heuristic in society is. And so hopefully I've said enough about that, but I think that makes sense. Katie, would you add or take away anything from what I
That's
communicated?
perfect. No, it's perfect. And I think like our big goal for this course is to help more, I think, just people in our movement professionals, an umbrella term. I put trainers, coaches, rehab providers all in that, because I think the more we can do together, the better we can help people at large, instead of feeling like we're separate, which I really don't think we are. And increasing confidence with navigating things that otherwise can be scary. So the patterns in people's pain history that they tell us, the program design variables that we talk through with clients to help understand what's like their body used to doing versus maybe what they're asking it to do, what's their training history. All of those things tell us a lot more about somebody's experience of pain than a specific diagnosis. So we're trying to like level the playing field. If low back pain is something that impacts 80% of people, every person who's a trainer is going to experience a client who has back pain. So the more that we can help everybody in our industry kind of realize like, okay, this is something that inevitably we're all going to run into. How can we best manage it? How can we not scare people? How can we rule out the stuff that we need to rule out? And then otherwise, how can we help people become more confident in understanding like you're going to encounter this stuff as a coach? We got your back. It can sound scary, but here's a few principles that we base our decision making off of that can help you also make decisions that can help people stay active.
I think that biopsychosocial model of pain is really important because, like, piggyback off what you guys are saying is so many practitioners start out with fear-based. And I remember when I was benching back in the day and try to hit that 315, arched a little too much, hit a little pop in my back, and exactly everything that Q was talking about, that pain. I mean, I was hopeless, and I go to a doc and I get an MRI, and oh, guess what? You have a disc protrusion. I'm like, what the hell's that? I thought a herniation was bad, but now I have a protrusion. Let's bring you over here to this little model on the table. And this is a slip disc, and your back is screwed. And by the way, you should never run, jump, squat, deadlift again. And we also want to cauterize the nerve because that's going to be your best bet. And I'm just like, wow, no hope whatsoever. And then when I met with Doc Craig and when I went to him, it was great just because just the humility, and it was just normal conversations. He didn't treat me like, oh, Chris, you have a little back pain, give me a hug. It's just like, how's it going? What's your background? Oh, you're kinesiology, that's cool. We're talking about people we know. And, oh, I know Waterbury and cool, and did a couple of tests. He's like, okay, I want you to do this over here, get up 10 times. I was like, I can't do that. He's like, I'll be back, you'll be fine. And I was just like, there's something in his tone and just his, I'm just like, there's some hope here. And when I started going through it, a lot of it just because of his disposition, it gave me hope. And I feel that there's a lot of people out there, they get this, prognosis, and they're diagnosed and there's just no hope. And so, when you go to courses like this, you're going to now have hope because you're learning from people who know what they're talking about and you've also experienced it. And, that's what we were talking about a little bit earlier is about, low back pain can be really traumatizing. And it's just unfortunate that people will try to simplify it by saying, oh, the reason you have low back pain is because you have knee valgus, and therefore then we're scaring you. And it's like, oh, don't deadlift anymore. Don't squat anymore because that's bad. And let's play around with some bands and a BOSU ball.
No, you bring up, there's like 2 points that I want to make quickly on what you said. The first one being of just mentioning when you were experiencing your session with Craig Liebenson, like his disposition and how he just spoke to you. That's a big thing that Q and I are really passionate about as well. And I think something that makes somebody a really excellent provider, and again, umbrella term, trainer, coach, rehab provider, something that makes them excellent is also just how they interact with the person in front of them, not the laundry list of certifications or the numbers and the letters after their name and all of these special fancy exercises. It's, can you make somebody feel safe without maybe like overdoing that and being a little bit too accommodating, because you still have to provide a plan and be, confident. Can you make somebody feel like, oh, he's not acting like I'm so fragile that I'm about to explode the second I do this. Maybe I can calm down too. And it's not being dismissive to your experience, but it's also taking a step back and being a little bit more relaxed with how we handle pain. I think that goes a long way. So that's a big part of this course too, is how do you actually communicate in a way that shows that you have the confidence to navigate what this person is scared of, but you're not dismissive, that you have the empathy, but also the understanding of like, if I'm not super tense about this, it's going to make the person less tense. I think that's very, very important. And so I'm glad you brought that up, because I think that is probably more important than any magic exercise than anybody thinks they could learn about navigating pain. It's like, can you talk to the person? Can you understand what this pain is taking from them? What part of their identity that they don't really feel connected to anymore? And like, how can you make them feel connected to themselves again? That's within all of our job descriptions. Like, that's exactly what we all do. And it's not just reserved for rehab providers. So I think that's a really important part of it too. And I got so excited about the first point that I forgot my second point. So that's, we'll just pivot from there.
Yeah. No, it's good that I think, yeah, and now maybe this is the second point, but like the two things that comes to my mind would be, yes, on one side, we're trying to instill confidence in people who are interacting with other folks that are experiencing low back pain, because they should know, hey, here's all the potential things that we do need to be concerned about. Here's all the potential things that we're ruling out that this is not. Once you've ruled out these things, and then Katie and I talking about what certain things to look for, patterns, signs, symptoms, whatever it might be with low back pain, just helping people contextualize and understand what this thing is that they're looking at makes it so much less scary, that you can have that type of demeanor. You can have that type of interaction, because Craig, for example, in that interaction, he's seen hundreds and hundreds and hundreds of folks with low back pain. He knows what's serious. He knows what's not. He knows what he's looking for. It's no longer the scary monster under his bed, because the monster's hanging out in the room all the time. It's a friend now. Like, it's not scary anymore. And so I think on one side of things, we want to help people see that portion. But then on the other side, saying, hey, here's all the potential things that should be liberating and freeing, all the potential things that you can do with it, given certain signs and symptoms. And it's not this very regimented protocol that you have to memorize, and it's only if you see this, then you have to do this. We're trying to help people see, yes, this isn't that scary for all these reasons. Here's what it is, but then also here's all the things you can do from a programming and exercise selection standpoint, and here's some strategies that we use with our clients or with other people, with certain, whether they're a catastrophizer or they're freaking out about their pain and they're really, really worried, or they're more of a confronter and they're looking to push through things. That's something we talk about. But there's a two-sided coin here, or a double-edged sword, where we're trying to say, hey, this is not scary, and then here's all the options you have to deal with it, that helps trainers and providers on the medical side face this thing with such a level of comfortability that will inevitably rub off on all the patients and clients they see, where now, if I'm not freaked out about it, they're not going to freak out about it. We've got options. I can talk about it very clearly. And hopefully what people walk away with from the clinic or the seminar, the course with us, is those types of tools that they can now go in, and they're not worried about flare-ups. because they're going to happen anyway. And when they do, here's how we talk about it. And you got a host of things in your tool bag, if you will, that you can just use and sift through and navigate it with people in all the ways that people do it uniquely with their relationships. And hopefully that covers.
I read a book, I think called Crooked back in the day, and Craig was mentioned in there. And one of the things that they said is they interviewed, I think, 100 low back orthopedic surgeons, and they asked them if they'd ever get low back surgery, and all 100 said no. But I'm sure that there are some times, but not to knock Western medicine, but a lot of times when you go to, if you're a hammer, you're going to find the nail. And if you go to a lot of these docs, they're going to say, well, let's get surgery. In your experience, are there times when there are, surgery is required? I mean, obviously besides like tumors and stuff like that, but are there times when, that has come up and you're like, okay, that's actually a good idea?
Yeah, absolutely. And that's what I think it's important that we talk about this too, because I've also had patients referred to me where, working with previous providers. And again, I think all of our goal is to try to keep things as conservatively managed as possible. But there's absolutely instances where it's appropriate to get another opinion, or where seeking out less conservative measures is the absolute right call for this person's safety. When things are unstable, when you have risk of bigger deal issues happening, if you don't get something surgically intervened upon, like that's important. If you've tried things for a very, very long time and there hasn't been a noticeable change that would be reasonable and logical to expect with the measures that you've put forward, we might need another opinion. It's not always the thing that is bad. Like surgery is not this like negative beast that we're saying is never appropriate. And I think that can get lost in translation sometimes, because by and large, unfortunately, we are over imaged and we are over cut. Like that is an absolute reality of our medical system. Even like talking with people about truly what the clinical practice guidelines are for when low back pain should be imaged versus not, we are over imaging by like exponential amounts versus actually what is truly based on literature and on clinical practice guideline recommendations that practitioners are supposed to follow. Most people getting imaging for their back pain don't have any of those things actually being met. So that is a very real thing. However, there's absolutely instances when it's the right call to have surgery. When we have neurological symptoms that are progressively worsening, when we have loss of strength that is neurologically mediated and it is not improving with training the area, that is absolutely when surgery is something that we probably need to look more into, but also still get opinions. It's more of like it's a way for us to acknowledge the fact that there are absolutely times when a more medical route is necessary. It's very similar with people utilizing diet and exercise to help with lifestyle things like blood pressure and other things that can be medically managed. There also are things where if you're making all of the behavior changes and things are still not moving in the direction that we would want them to, maybe medicine is appropriate for you. And keep doing the stuff that is the positive behavior change, but maybe it's appropriate for you. And so that's okay too. There's absolutely instances when I meet with somebody and I say, hey, I think we need another opinion. Or we try things for a very long time and I say, hey, I think it's time that we look at another opinion. So we have to be able to know when that is appropriate, but it not be our knee-jerk reaction when somebody has pain.
Yeah, I think that it does get into this category, especially with some of the speaking to the converted here of people that are already kind of more in the category of like, I know exercise is, necessary. I know that movement is good. And then sometimes if somebody gets surgery or is leaning towards the need for surgery, they see it as just a total, utter failure, and they just see it as such a bad, bad connotation that, oh my gosh, you need surgery. You've really messed up and your life is forever going to be changed. Well, we know that like that side of the coin is probably too far on that end of the spectrum, that people do benefit from surgery. What we can say is that on population levels over hundreds and thousands of participants, that for chronic pain, things like surgery does a very, very poor job at solving things like low back pain. That surgery for low back pain is very poor in terms of its ability to change pain relative to if they just pursued more of a conservative management type strategy. But that's population level data. That doesn't account for all the very nuanced one N of one or individual situations like what Katie was saying, where you have progressive loss in neurological mediated, pain or loss of function, loss of sensation. Even people who, you've come at this problem for a long time, years of all kinds of different strategies of how to manage this thing, and it just continues to be so debilitating and it's progressively taking more and more away from them in life. Yes, perhaps surgery could be an option, and that should be seen as like, hey, guess what? It's not that you failed and you've reached the end of your line. It's more of, hey, here's another potential route that you still have on the table. We're just trying to keep that option on the table as long as possible, that we don't have to cash that check as early in this process, because we know that 95% or more of people will not need the surgery, let alone that, of those 5% who get surgery, maybe a very small percentage of people will actually benefit far and away greater than had they not. And so, yes, while we have on one side of the coin that this thing of surgery and overimaging has been far overdone, and that when you go and see a cutter, a physician, the thing that they're going to do is to cut. That's what they do. And their triage in their clinic of somebody who does orthopedic spinal surgery is they need to decide on that day in that visit with you, am I cutting or am I not cutting? Because if I'm not cutting you, like, I don't have a need for you in my office and you don't need to be here either. This is like, time is money and this isn't the place for you. So I need to decide triage wise, like, am I doing surgery or not? And unfortunately, because of the system and the way it works, if there's something that I could cut on and I could surgically fixate, oh, well, I have to tell you that, like, yes, I can do surgery. And I think that heuristically, from a societal norm, they hear, or patients hear, oh, surgery could be done. Oh my God, I need surgery then, because how is anything that could be potentially fixed with surgery ever going to change if I just do physical therapy? That doesn't make sense. So I think there's a lot lost in the communication there, and that's why we err on this side, the same way that in the nutrition space or the fitness side of things. Yes, is protein important? Yes, protein is important. However, if you're not resistance training, you're going to be anabolically resistant to that protein. That, like, a quote that Stu Phillips used earlier, he said, resistance training bakes the cake, and that protein is really just kind of the icing on the cake. But, like, I think what we're saying is that surgery is not useless, that it's not this horrible thing that things should be avoided at all costs. But just like the icing on the cake, it's a part of some people's medical management. It's just so overly pushed and overly done so often that, yes, we're going to push against that. But we're not trying to say, and maybe what gets lost in translation, that surgery is completely useless. And I hope that this conversation, people are gathering that, like, yes, in 90% plus of these cases, surgery is not the answer. That does not mean that if you get surgery, or that if surgery may be indicated in certain cases, that you failed and it's the worst thing ever and you're just debilitated for life, because you can also have good outcomes with that. I hope that's clear.
Absolutely. And
For sure.
And I think that's the great thing about pain science. It's so fascinating. And I know there's a lot of trainers like me, when I first started learning more about it, I wanted to learn more. And I went to lunch with the prehab guys, Dr. Waterbury, and I'm like, hey, what are some resources you guys can give me? And they gave me one of their USC textbooks, and it took me about 19 years to read 4 pages, but a little too esoteric for my dumb trainer mind. Are there some resources that you found that, not necessarily dumbing it down in a bad way, but I love Dr. Lorimer Mosley, because I think he has a great character in the way that he just presents it. It's funny and it's easy to understand. Are there some good similar or, additional resources that you suggest for the pain sciences?
Yeah, it can definitely become a little bit more like esoteric and philosophical, which if you like that stuff, it's awesome. But if you want a little bit more, I think on the practical side too, Instagram is a great resource for people who practice in this way and talk about it a lot. Ryan Chow from Reload, when he goes in his zone and writes on his stories some of the things that he's thinking about, it's always very simple but like heavy hitting concepts. Like, he's a great person to follow to just kind of go through his brain and how he navigates things. I like the person that you mentioned as well too. Tame Pain is another good resource online too. There's a few Hannah Moves on Instagram. So Nick Hannah is a great resource for kind of the psychological and social implications of pain, but he explains them in a really like beautiful way. Like all of his posts are very artistic and just like it's very I think the way that he explains pain is awesome and a little bit less, I think, esoteric. That's a great resource too. Those are some of my favorites.
Yeah, I'm trying to think. In addition to that, the Modern Pain podcast.
Mm.
Cargila, I'm trying to pronounce his last name. I can't remember his Instagram handle. I think he does a good job. I mean, there's people in our space that are kind of the folks that a lot of people may be familiar with or look towards. Eric Maida. Then you have like Ben Cormack and Greg Lehman that talk a lot about being skeptical in this pain world and how it's not as clear or straightforward as some people make it sound. You know, those are pretty good resources to start dipping your toes. And I think Barbell Medicine Group and E3 Rehab do
For
great
sure.
jobs in this space, both with what they put out on blog posts as well as from their podcasting and YouTube videos that they create. We're obviously going to miss a lot of folks here, you know, in listing of all the people that we look to or listen to that do a good job in this space. But I think that instead of like saying these specific people, listen to them, I think from zooming out even more, if you're listening to content that is very certain, where they say, if this, then this, I
Yeah.
would be skeptical. I would just be skeptical. And I tend to listen to people who have a lot more nuance or a lot more zooming out and saying, we don't know a handful of things. Here's some things that we kind of generally land on. How that looks for your individual, you know, patient in front of you may be different. I like Nick Hanna, for example, because he uses a lot of just general analogies that would be true if there's something that could be applied to the physical therapy spaces that would also be true for things like mental health space or that have the ability to transcend the world of just physical therapy from more of a philosophical or the way that we look at how we interpret some of these findings in the research, I think those are generally going to be very good people to listen to because it's full of something that we experience as humans across all different domains of our lives. That when we look at physical therapy and pain, some people want to get very pathoanatomical and say, you have pain because of this slip disc that's now pushing on this specific nerve root that's causing this very specific type of pain. And if you rotate to the left by 30 degrees, then that will fix your pain. Or if you just do these repeated extension exercises, or you need to strengthen your core and stabilize it because the spine needs stability, or, you know, never do these types of exercises, it starts becoming further and further away from what could be applied at broad to a lot of other things. And I think that from a general concepts perspective of the people that you're listening to, I would be very skeptical of people who want to get very in the weeds of pathoanatomical type nature of findings and biomechanical nature of things because it's just not that reductionist. It'd be great if it was. I personally, selfishly, I would love if it was
I
that
wish.
simple. Yeah, I mean, it would just make our job so much easier if they're like, oh, yeah, every time you see this, you just do this. And it's unfortunate because people that believe that or that sell that type of stuff, yes, it does work. It just doesn't work for the reasons why they think it works. It's that anything could work, especially when you're dealing with people with chronic pain. Any number of things could potentially flare them up, and any number of things could also be really positive for them. Anything that's just simply different could be positive. Your, as a clinician, your confidence in your treatment, as well as their confidence in the clinician's treatment, is one of the biggest players in people's actual real perception of pain experience and quality of life improvement, as anything has ever been shown in terms of the specific exercise selection or program. So, like, there's just so many contextual things that are baked into this, and that doesn't mean that we should just say, like, oh, placebo is useless and don't play up the confidence in what you're delivering. But I do think that there's a lot of folks who feel very confident about the systems and the protocols that they've put in place because they quote unquote work for their clients. But then you have so many people who do the exact opposite or a very different strategy of things, and it somehow magically all works for their clients too. And so I think just helping to zoom out and say, hey, maybe it's not as very, very intricate and specific as we would like it to be, which is the illusion of modernity, is that we have all this technology. And so therefore we should be that specific in healthcare by this point. And frankly, it's just not. And I don't think it ever will because of all of the nuanced complexities of what goes into what causes pain and why at different time points it's a moving target. So if you can just zoom out and think from bigger, higher level picture, I think that also takes down this imposter syndrome of people thinking, oh, if I just get enough certifications and if I just know enough, I could finally treat people with low back pain in the perfect way. And it's like, no, we're trying to give you the like tools that will be the gift for the next 20, 30 years of your life of working with anybody in any kind of pain, in any kind of situation, both from training frustrations, of performance side of things. I'm not making the gains or losing the weight that I want, as well as I'm not making the gains or losing the pain that I want over here in the clinical side.
One of the difficulties that I have as a teacher of trainers is I get a lot of people who are really enthusiastic about learning more. And I don't necessarily want to crush their enthusiasm or, be sitting over here on my high horse, but they'll be saying things like, oh, I'm really excited to get my corrective exercise certification. And I'm like, my mind goes, well, that's stupid. It's not going to do much, but or I'm going to do this PRI course. I just got this Anatomy Trains book. I'm really excited, and Supple Leopard, and I love following Milo and Squat U. And I just kind of let it, okay, that's cool. But I try to, steer them towards more, oh, check out this podcast over here and listen to this. And I don't want to make them feel bad because, especially with trainers, the education is just really easy. You take and ask them, 120 questions, and all of a sudden you're certified. And then you learn about, PRI, and you're, oh, okay, I want to learn more about that. And then it makes sense. You think, oh shit, I never heard about this angle. That's pretty cool. It must be, I got to go blow up a fucking balloon for the next 3 days. And then they get some buy-in, but it's like, I don't want to discourage it. So, how would you coach me to, better, whether it's navigate these enthusiastic minds? Because yeah, it's great to learn, but do they need to make the mistakes that a lot of other trainers have done where it's like, yeah, I didn't need to do that course or that course or that course or that book?
It's a great point. And I think it's easy to be on the other side of things and now say like, oh, that stuff isn't important. I think there's a little bit of I think a very common thing when somebody enters a new career field or is trying to level up in some way is to get excited about it and find everything possible that they can do in a way that they think it's going to make them excel. And I don't think that's a bad thing. I think going through that process and learning how to, for yourself, determine information that aligns with the way you want to practice, that aligns with evidence, that aligns with your thought processes, or that goes against them. Like, I think all of that is valuable and important. I think where it gets messy is when we basically hold ourselves, we become beholden to a system that we now think we need to do everything based on what the system says and put every human being that we work with in a box to fit what it says. So that's where I think what Q is saying is helpful as well. Like, I don't necessarily think there's something wrong with seeking out this information and doing a bunch of courses, especially as you're newer or especially as like you're getting excited about things, but have antennas up. Are people speaking in absolutist claims? Are people saying that everything else out there doesn't work and is stupid and this is the only way? Do people have actual things that are like biologically plausible? Like we talk about this a lot with critiquing literature, like or just any sort of claim that is being made. Like, is it plausible that this like physiologically, biologically does something? I think we have to be better at discerning what type of information is that we're getting information from. But I don't want to say like don't go and take these courses, but actually think about the information that you're consuming. And I would venture to say if anybody out there 100% of the time believes that their system is the answer and the only answer, I would say look elsewhere. And I think we could probably agree about that on every aspect of life. Like we could get into any topic of discussion. And if somebody only looks at one answer for one thing over and over and over again for every single instance, it's probably not something that you want to dive into either.
Yeah, I think that to piggyback on that, it's we just have to say that no matter what you do, it has to have some kind of biological plausibility that it's reaching some level of intensity, whether from a load, from a rep scheme, from even neurological intention and attention to the thing, to distract enough to reach some kind of even neurological synapse making type intensity. Like it has to have some kind of element that's related to it that it would drive some kind of adaptation potentially, and beyond that, whatever system or thing people want to do, that's fine. And everyone's going to go through their own learning process. And I definitely try to just live and let live mentality, and let people practice the way that they want. I think where we see the biggest pitfalls is then the narratives that are delivered to clients, the narratives of the why behind why we're doing this. And frankly, we just don't know. When you go to any kind of course, we've talked about the PRI, the DNS, FRC, whatever kind of stuff, there's a lot of times where the practitioners of these courses will really oversell it from a biological type thing. They'll say it's doing this to this tissue for this reason. And most of that, if not almost 100% of it, is all very theoretical. And yes, while it works on paper within their system to say it that way, and then they'll give you some demonstration of why, and then now it all kind of wraps in your mind to this biases of, well, now I'm looking through this lens, and well, they said it works this way, and now it feels that way, so therefore it must be true. And well, screw the research then. The research just hasn't proved what these geniuses have come up with. Like, you still have to be grounded and rooted and understanding that, like, a lot of that is circus tricks, and it doesn't work exactly the way that they may claim that it works. Now, it can work for people, so go ahead, use it. If it works within your clinical space and clinical model, and you're still training and you're still moving the needle in some adaptation, you're helping people get better, that's fine. We don't discourage that, or discourage people from going out and trying to learn. It's just that I think that sometimes these things get wrapped up in really poor narratives. And the other thing that comes up is the opportunity cost. If you're doing these things over here, whether that's manual therapy or palliative care, or you're just doing these kind of silly, nonsensical, corrective exercise world of things, it's just, what is that taking away from? And what is it replacing? Time and energy and resource is not limited, or not unlimited. All of these things have their limits, and every minute or ounce of time or energy that you're putting into one thing is inevitably taking away from another. And so that's where we kind of come in and say, hey, you know what? We already have an epidemic of people not participating in physical activity guidelines. We know that most people are not training. They're not engaging in these things to a level that would cause adaptation. And this isn't unique to physical therapy or training. Even when we look at studies from a pharmaceutical standpoint of how many people are actually adherent to taking the medications when they've been prescribed medications, these drugs for very specific pharmaceutical reasons, for very specific pathologies and diseases, like, even in that side of things, that adherence, people are really only about 50% adherent in these pharmaceutical studies that get ran. So this is a human problem. This isn't just like a training and physical therapy kind of problem. People are just not adherent to things that will benefit them in general. And that if we're taking people further away from these long-term things that play downstream effects, we just have to acknowledge that there's going to be a real true cost to that person. And that's where we're trying to emphasize, not that we're wanting to just impromptu shit on everything that isn't what we do specifically. It's just that you have to acknowledge that, one, there may not be biological plausibility or research or evidence to really back up a lot of the claims, no matter how much sense it makes in the sessions that you go to or the clinical education courses you go to from some of these folks. And that, two, every amount of time and energy does have an opportunity cost on what could be paying bigger dividends to people's health and what makes a sustainable healthcare model, which we need to move towards, especially in westernized culture.
I'm a little biased. I think that we have the best personal training certification out there, but we're not backed by private equity. But one of the things we are, prideful in is that we require the trainers to get a therapist and an RD on their team, so you can have those conversations. Because it'd be easy for me to go to Doc Q and be like, "Hey, I'm going to get this, NASM CES," and he goes, "Well, no, let's go over here and let's talk about this." And he can, kind of guide you. And instead of trainers trying to be this jack of all trades, we're really big into, building that team around you. And we love hands-on learning courses. And that's exactly why we're suggesting for people to go there. And because this is our 400th episode, we wanted to, give Katie a free pass for one of her followers. Same with Dr. Q. And we're going to give one to our CPT followers. So if you follow everyone, throw it your story, we're going to choose people and we're going to give out 3 tickets. We're really excited. When is this going to be? And can you give us a little more details?
Yes. So we will be in Austin, Texas at the C4 Performance Facility on Saturday, September 12th. If you guys just look up that facility and see how awesome it is, it's one of my favorite gyms that I've ever been to. So we were really excited to have the event there. The Coach 'em Up podcast did a huge conference there, and we were just there as well. And it's a really beautiful space. The C4 Performance Facility was very generous to basically offer 8 to 10 a.m. before the course starts is an open gym and use of any of the facilities. So including the fields outside, the gym itself, all of the recovery amenities, the sauna, cold plunge, hot tubs, things like that. So we're definitely going to be there getting a fun lift in before the course starts. And then from 10 to 4, we'll be going through a mixture of lecture, case breakouts, discussions, and movement and training together to really help people feel confident navigating low back pain, keeping people training. Something we're really excited about is we're going to literally go through exactly how Q and I would program an athletic session for somebody actively experiencing low back pain, as well as strength and hypertrophy and power sessions for somebody actively experiencing low back pain. Like, how do we actually do this so people can keep training? We cannot wait. We're so excited. We also, for those of you listening to, if you head over to the Eventbrite page, which we'll make sure that we give you guys the link, Show Up Fitness at checkout also gives you a $50 off code. So another great way to save. And thank you so, so much for having us so we could talk about it.
And I think I saw, I'm getting old. I know Q looked at my gray hair when he was talking about that earlier, but I think I saw an asterisk after because of the Texas-Ohio State game. Q's buying whiskey, so really excited for that one, right? Did I read that on there?
Yeah, that was definitely in the fine print, for sure, for sure.
Yeah, Texas Ohio State will be playing. Whether there will be whiskey provided, that's TBD.
And where can people find you on social media?
Instagram's a great place. If you just search my name, Katie Dabrowski, you'll find me. My facility in Miami, Old Bull Athletics, is another awesome resource to see what our phenomenal team of hybrid rehab providers and strength coaches are up to. Great education resources there as well, and kind of practicing what we preach, like blending the worlds of training and rehab and purposefully making them so they don't look different when you walk into our gym.
Nice. Yeah. And for me, social media handle is coach_Q_physio. If you just look up Q Willie, my last name, Willey, you'll find probably a host of different information, podcasts, and social media things that you can find me on as well. So no, we're stoked to put on this course, give the Show Up Fitness folks and people listening to the podcast a good little discount here, as well as provide 3 tickets to folks that want to come for freezies. We'll be putting out some information on that as well.
Well, this is awesome, you two. Thank you guys for taking the time to chat about this, and looking forward to that seminar. Thank you.
Thanks,
you. Chris.